Thank you to Nicole for that very nice introduction. I hope I can prove myself worthy. I get the lucky slot of talking after lunch, so hopefully no one finds time for a nap and we can keep this engaging and interesting. So I'm going to be talking about battery ingestion, which is going to be a little bit of a change of pace, considering what we usually think of as pediatric trauma. Let's see if we can get our slides to advance. There we go. I have no disclosures, and very importantly, I have no financial interest in Energizer, which you will come to question at the end of the talk, but I really have no interest at all. So why talk about battery ingestions at a pediatric trauma conference? It's, not exactly what you think of at first when pediatric trauma comes to mind. The usual trampolines, ATVs, skateboard accidents, those are much more what we think of that comes to mind. But these batteries, small as they are, can certainly inflict pretty significant injury, and that's what we'll be talking about today. Every once in a while, a story about this will pop up in the news, and I don't know if anyone picked up on this story. This was just last week. This was a toddler in the Las Vegas area who died under mysterious circumstances back in September. There was really no cause that could be determined. The family went through rigorous questioning, and child abuse, I know, was certainly on the minds of those involved in the case. But at the autopsy, they actually found that the child had swallowed a battery. And so this continues to be a problem. So today we're going to talk about the scope of the problem. I hope that at the end of the talk you will be able to at least have an understanding, if not technically describe the mechanism of injury, but we'll talk about how it happens and why. And we'll go over some radiographic signs of battery ingestion, helping you tease out which is the coin and which is the battery. And then we'll also discuss what has been done to help prevent this problem. So devices that have button and disc batteries are really ubiquitous in our homes these days. One of the most significant contributor is the remote control device, specifically smaller remote controls. And I think all of us here probably don't know a single child who hasn't always wanted to be grabbing for that remote and playing with it and always winds up in their mouth. I have a 15-month-old right now, and that's what he goes for. It's the cell phone or the remote control. It's one of the two. And these really can be dangerous devices if the battery compartment is not secured appropriately. So as far as incidents, in the US, a child can be seen in an ED with a battery-related complaint as frequently as every 3 hours. And we're seeing that more and more consumer electronics are powered by these button and disc batteries. And kids are able to access these batteries in a multitude of ways. A majority of them are actually obtained directly from the product, about 60%. But 30% of ingested batteries were actually loose or discarded, and about 8% were actually obtained from the battery packaging itself. So what does the data say? If you look at the wealth of information that's out there, there are really three primary sources. There's the National Poison Data System, as well as data collected by the National Battery Ingestion Hotline, and then what's reported in the medical literature. Between 1985 and 2009, there were over 56,000 ingestions reported. And in data collected by the Ingestion Hotline, between 1990 and 2008, they had about 8,600 cases. And just note, though, that these are also recording cases of cylindrical battery ingestions, but the percentages of those are far fewer. For example, out of the 8,600 reported to the National Battery Ingestion Hotline, only 400 to 600 of those were actually cylindrical batteries, with the remainder being the disc and button batteries. And there are 36 significant cases reported in the medical literature, and as you would expect, if they're making their way into the literature, those are probably patients that suffered fatal or bad outcomes. And then I didn't put it in here, but there was an additional case that was not in the literature, but was reported in the media. And so pooling all those sources and cross-referencing for cases that have been reported and show up in multiple places, in this time period, there have been 13 fatal ingestions and 73 life-threatening cases. So when you just look at the data from the National Poison Data System, they've recorded an estimate of 6.3 to 15.1 ingestions per million annually. So when you look at it that way, you're like, well, that's not very frequent. But I think the important data comes in the fact that a majority of those, almost 70%, occurred in children under 6 years of age. Only 20% were in children older than 6. And I think key piece, though, is that the clinically significant outcomes, the patients who've suffered injury from these battery ingestions, when you look over 25 years, it's only 1.3%. But the trend is that rate of injury is increasing. In that first 3-year period, less than 1% of those children suffered injury. But over the last 3 years of that data, the rate of injury is up to nearly 3%. And so if you look at it graphically, which I think we lost our mic there. I'll just keep talking loud. Never mind. Sorry about that. Everyone okay? Anyone need a hearing aid? I might have some batteries. Okay. When you look at it graphically, you can see that over time the incidence of ingestion really is kind of all over the map. But the clear trend is that if you look at the black line, that's the incidence of injury, and there's a clear marked increase over time, and we can only worry that trend is going to continue. So the data from the National Battery Ingestion Hotline showed similar data in that about 60% of the ingestions were in children under 6 years, so that's pretty consistent. The data they collected showed that 4 battery types, or 4 battery sizes actually, accounted for nearly all of the ingestions of those with a known diameter. About 55% were 11.6 millimeters, 30% were smaller than that, 6% were the 20 millimeter batteries, and those are the ones that are the lithium batteries that are more commonly used now. And again, here the trend is that in the first 3 years, only 1% of the ingestions were those 20 millimeter batteries. And now over the past year of that collected data, it was up to 18% of ingestions. And we'll talk about why that's really important. And then the teeny tiny batteries, the 5.8 millimeters, were 3%. So that 1% to 18% increase for the 20 millimeter lithium batteries is really the significant factor as we look at this. So this is a graph that shows you the incidence over time of the different sizes of batteries, and the solid black line is the one to pay attention to. That's the 20 millimeter lithium battery. Now, this really just was looking at the size of the battery, but because almost all of the 20 millimeter batteries in use are lithium, then it correlates. And so if you look at the graph of the battery types, not by size, but just by chemical composition, again, you see the same rise in the lithium batteries. So let's talk a little bit about the types of batteries. They come in a huge range of sizes, and people will call them button batteries, disc batteries. The terms get kind of tossed around interchangeably, and I've kind of categorized them into 2 types to ease our discussion here, but essentially there's not a standard in the literature for what the nomenclature of these is. But the smaller button type ones are often the hearing aid batteries. They come in smaller diameters, and they have a much more varied chemical composition. There are zinc, manganese, silver oxide. The mercury ones are no longer in production. And these tend to cause a slightly more caustic alkaline electrolyte leakage when exposed to tissue. But these are typically lower voltage batteries, only 1.5 volts. And again, as I said, these are more commonly used in hearing aids. The disc cells are the 20 millimeters or greater, and these have a higher voltage. These are 3 volt. And as I said before, virtually all of these large diameter button cells in households are lithium. Now, interestingly, the lithium cells leak only a mildly irritating organic electrolyte. And so if you look at just the chemical composition, they are not nearly as injurious as the smaller ones. But as we'll talk about next, it's really not the chemical composition that's the big problem. Another important feature is how to identify these batteries. The typical 20 millimeter battery will often have an imprint code CR2032. The CR designation refers to the lithium manganese dioxide chemistry. Sometimes that'll be DL instead of CR, but most commonly CR is used. And then 20 stands for the diameter of the battery, and the 32, which is actually 3.2, stands for the height of the battery. And that can be helpful in the emergency department as you're trying, if the parents have brought in a companion battery or the package, as you're trying to figure out what is your urgency to get this battery out. And there are several other sizes kind of in between these two broad categories. So as far as outcome predictors, battery size trumps everything else. In looking at the literature, 31 of the 33 cases that had fatal or major outcomes, again in patients in whom the battery diameter was known, 31 out of 33 were the 20 millimeter or greater diameter batteries. The second predictor is age. All of these, every single fatality, all 13 of those, and 85% of the children who had major problems were all under the age of 4. So if you see in your ED someone less than 4 with a 20 millimeter battery, your radar should be way up. Now, interestingly, new cells are more likely to cause injury, but in the logistic regression of all the data, they didn't really surface as a predictor when all battery sizes were included, because most of the small batteries are going to pass spontaneously on their own. And so even if they were new or old, it didn't pan out. So in the data, it didn't serve really to be a significant outcome predictor. If you're in the rare situation to see a patient with an ingested battery and a magnet, there were 2 cases of those in the literature. Both of those required surgical intervention. And as I said before, the chemistry of the battery is not as important, because if you look at the outcomes of the lithium cells, the ones less than 20 millimeters really had no worse outcomes than other ingestions of the small button cells. So it's really size that's most important. So what can we learn from these fatalities? So between 1977 and 2009, there were 13 reported fatalities. And again, as we talked about the trend, 6 of those occurred in the last 5 years. Again, they were all children under the age of 4. Only one of the ingestion was witnessed, and the diagnosis was missed by healthcare providers in over half. Those batteries were in the esophagus for 10 hours to 2 weeks before the battery was removed or the patient died. And in over half of those patients, massive hemorrhage was the cause of death as a result of esophageal fistulas, either into major arteries, or most of those were into the aorta. And the scary thing is, up to 18 days after battery removal, delayed bleeding could be seen. And when we look at the larger group of all the patients who had significant outcomes, this was that group of 73 patients. Again, the common trend is that almost all of those were in children under the age of 4. Half of these were not witnessed. 19 of the unwitnessed ingestions were initially misdiagnosed, which was about 46% of those, almost half. And misdiagnoses were due to the non-specific symptoms that the patient presented with and failure to recognize ingestion. So in some of those patients, there were films showing the coin or showing the battery, but it was misidentified as either an EKG lead or some external object, a coin, or in some instances, the battery was not able to be captured on the radiograph. It was outside the radiograph border. So this is really our key problem, is that as healthcare providers, you've got to tease out in your mind, is the little toddler who's drooling a little bit and wheezing, how do you link in your mind, oh my gosh, this could be a battery ingestion, let's go. So let's talk a little bit about the timing of removal. And this is, I think, where it gets scary and puts the hairs on the back of our necks up. In some of those patients who had really bad outcomes, there were 3 patients who had their batteries removed in 2 to 2.5 hours after ingestion. And that's not a lot of time between the battery ingestion happening at home, mom realizing it, bringing the kid to the ED, getting the x-ray, getting the right consult made, and getting that kid to the OR. I mean, that's a short period of time. And in those 3 patients, they had significant enough esophageal burns to either require frequent esophageal dilatations for stenosis or tracheostomy for stridor and vocal cord paralysis. So the clock is really ticking. And the causes for delayed removal are varied. When they looked at all these individual cases, some of them were due to parents' failure to seek medical care. You know, a kid who's kind of wheezing and doesn't want to eat. You know, you may not necessarily think that that's something that's got to go directly to the ED. They may wait a day at home before it's figured out. Misdiagnosis is a huge problem. Failure of the healthcare providers to recognize the need for urgent removal. The time it takes to transfer to a pediatric specialist. And sometimes insistence on fasting prior to anesthesia. So a little bit about the complications that can be seen. And again, this is focused on that group of 73 patients who had bad outcomes. Tracheoesophageal fistula was seen in up to half of those and can sometimes be diagnosed as late as 9 days after battery removal. Other esophageal perforations were seen in about a quarter. Esophageal stricture or stenosis in nearly 40%, and those are usually evident in the weeks to months after. Almost 10% had vocal cord paralysis from recurrent laryngeal nerve damage. And then there's a smattering of other possibilities, including mediastinitis, cardiac or respiratory arrests, pneumothorax, pneumopericardium, tracheal stenosis, tracheomalacia, ad nauseum. The last one there, the spondylodiscitis, was seen about 6 weeks after battery removal. So I don't know if anyone's been in the market for a house, but it's all about location, and that's the same for these battery injuries. The location of the battery, where it lodges, and the position of it can really help the medical professionals predict what type of injuries they might be facing. So to start off with some esophageal anatomy, there are a couple characteristic or anatomic narrowings of the esophagus that can prove to be the point of obstruction for the battery when it's swallowed. The cricopharyngeus muscle up top is probably the first spot, and that's probably the most likely place that these batteries will get lodged, is above that level. If it makes it through there, then sometimes it'll get caught up around the level of the carina, where the bronchus can add some extrinsic compression on the esophagus. And here's another view of the airway and the esophagus. So just, this is as if the posterior portion of the pharynx is cut away, and you're looking at the glottis and the airway anteriorly there. And I show this one because, again, it shows the cricopharyngeus as that narrowing, and you can see how if a battery were to sit there, how that's right behind the trachea. But then also it shows a depiction of one of the recurrent laryngeal nerves on the side, and you can imagine a battery wedged so that the edges of it are up against the lateral portion of the esophagus, hitting a recurrent laryngeal nerve on each side, and how that can cause injury. And then here's one that shows a diagram that shows the relationship of the esophagus, the trachea, and the aorta. And you can see how the aorta and the esophagus run along each other, and how lateral compression against the esophagus can erode into the aorta. All right, so mechanisms of injury. There are actually 3 proposed mechanisms and that have been tested in lab animals. But the first is that you can get leakage of a caustic alkaline electrolyte. And this plays some of a role, but it's not the major component. The second proposed mechanism is that there can be necrosis caused by direct pressure of the battery in the esophagus. And although this is a theoretical concern, they have tested batteries that are completely devoid of charge, and when left in the esophagus, just the pressure alone is not enough to cause any significant injury. The real problem is the production of a current that is a hydrolysis reaction that creates hydroxide at the negative pole of the battery. And essentially, the esophagus, or whatever human tissue is touching the battery, the positive and negative poles, connects that circuit and is able to generate that reaction. and tissue pH can rapidly climb to above 10. Now the esophagus is really designed to withstand some fluctuation in pH, and it does much better with acidic pH than it does alkaline. You know, sitting here after lunch, maybe burping a little bit, that's gastric acid that's going up to your esophagus, and it's built to tolerate that. But alkaline exposure is much less tolerated. And the higher the voltage of the battery, the faster that process happens. And fresh batteries have been shown to be about over 3 times more likely to cause clinically significant injury. But I think the scarier thing is that batteries you consider dead or that no longer have enough charge to run the device still have enough voltage to cause injury. And so even when you're taking a dead battery out of a device, you've got to be careful and dispose of it so that a child can't get to it. All right, so if you take a hot dog, just to give you a visual, cut a slit in it, slide a battery in. This is 3 hours later. It doesn't take much time. You can already see that char. And if you cut the hot dog open, you can see the effect. And pay attention to how one side of the hot dog looks worse. It has much more char. And that is the side that is exposed to the negative pole of the battery, which is the side that's facing up in that picture. Additionally, if you drop a battery in saline, here you are at 0 minutes, and you can see how the chemical reaction is happening there. That's the negative pole of the battery that's facing up, and you can see that's where the reaction is being generated. So here we are at 1 hour, 2 hours, and you can see all that corrosion just building, 4 hours and 5. So you can imagine what would be doing to the esophagus of a child. So, as far as how to manage this, and I think it's kind of a complicated algorithm. This has been one that was devised and refined by a group of physicians on kind of a battery injury task force. And this has been published a few times in the literature, most recently updated in the International Journal of Pediatric Otorhinolaryngology this year. But we'll kind of walk through this algorithm. But this is a great resource if you want to print out a copy of this algorithm and have it in your emergency department or have it readily accessible. So if you have a battery ingestion that's known or suspected. Oh, let me back up. There we go. So you should suspect a battery ingestion in these situations. A story of a coin. Maybe there's an x-ray, maybe they're coming from another hospital and they're billed as, toddler swallowed a coin. That should raise the little hairs on your neck, and you want to make sure that before you assume it's a coin, you want to make sure it's not a battery. And some of the radiographic signs that you'll look for is there's a characteristic halo with a battery that you don't see with a coin. And then also in the lateral view, you kind of see a step off, and we'll get to some pictures that will show that. But I think the trickier ones, the much trickier ones, are the kids who come in with wheezing, they kind of act like an airway obstruction, or they're drooling or vomiting. Maybe they've got some chest discomfort, but how many toddlers are able to really tell you that? Or they've got difficulty swallowing, decreased appetite, refusal to eat. Really, oftentimes this could be 100% of the kids come into your ED at any one time. But it has to be kind of on your radar. And I think this is our biggest challenge because the clock is ticking, and so you've got to have the clinical acumen to figure out how do we screen for this. And there's also a role for those in the field. Now granted, most of these kids are probably brought in by parents, and if they're sick enough to require EMS, then there's probably not a good history for an ingestion, and so there may not be that thought to bring in a battery package. But if for some reason in the field there is concern that a battery ingestion could be the source, then see if the parents have an extra battery they could bring in, or the device that it came from, or the package that it came from, because that'll be a big help to the people in the ED in sorting out the danger of the situation. Oops. So now we've arrived at the point that you do suspect a battery ingestion. First thing is just keep the child NPO until you've ruled it out by x-ray. Ask a caregiver if they have a comparison battery, if they brought anything with them that might help you determine the size, or the imprint code, as we talked about earlier. And then this is an important phone number. You might want to write it down, but it's the National Battery Ingestion Hotline. If you don't have the algorithm and have questions about how to manage it, then you can get them on the phone. They've got a nurse answering the phone 24 hours a day, so that you could get some guidance on management. I happen to have the number programmed into my phone, but the wonders of phones these days. So at this point, the algorithm kind of branches into two branches, for lack of a better word. You've got either a patient less than 12 years old, all those kids will get an x-ray. Or if they're older than 12 and have ingested a battery greater than 12 millimeters. And the reason the 12 millimeter cutoff is there is that if a battery is less than 12 millimeters, you can assume that it's a hearing aid battery, it's small, and the risk of that battery becoming lodged is extremely low. Granted, your risk of having it being lodged in a younger child is higher, so it's really only for the older children who you think of ingested a hearing aid battery can you forego imaging. So all young kids under 12 and any kid older than 12 who's ingested a battery greater than 12 millimeters, they all get an immediate x-ray to locate the battery. Now, if they're older than 12 and the battery's less than 12 millimeters, you've got to answer these questions to make sure you can proceed. If they've been asymptomatic since ingestion, there's only a history of one battery being swallowed, there's not a co-ingested magnet, you're certain of the size of the battery, and there are no pre-existing esophageal diseases that could predispose them to having a battery be lodged, say, wouldn't you love it if your esophageal atresia patient 15 years later who has a small stricture comes back and has swallowed a tiny battery. And then also make sure that this patient has reliable caregivers. If you can answer yes to all of those questions, then that's a patient that you could manage at home. They could have a regular diet. You could educate them on how to strain their stools looking for the battery, and consider an x-ray to confirm passage in 2 weeks if they've not found it themselves. But if you cannot answer yes to every single one of those questions, then those kids also get an x-ray. And if at any time one of these older kids becomes symptomatic, go back and get an x-ray. So now that you've gotten your x-ray, your first question is the battery in the esophagus? If yes, then those patients need immediate removal of the battery. An endoscopic removal is preferred because you can visualize the tissue injury. For coins, there are other documented means of removing a coin, sometimes with fluoroscopy and a Foley catheter, where you under fluoro, put the Foley down, inflate the balloon, and pop the battery out. But unfortunately for battery ingestions, you may be able to get the battery out that way, but it doesn't allow you any way of visualizing the injury to the mucosa. And you may say, well, it's not really going to change anything that might happen to that child in terms of outcomes, but it does help you predict what complications you should be expecting, especially if you can figure out which way the negative pole of that battery is facing. So if the battery is not in the esophagus, it's either in the stomach or beyond, then ask, was there a co-ingested magnet? Probably not. If there was, remove it. But if not, which is going to be most of the times, answer whether or not the patient is symptomatic. If they are, then go get it if it's in the stomach, because it should be retrievable. Beyond the stomach, though, it's nearly impossible to get it endoscopically, and you would reserve surgical intervention for patients who have evidence of bleeding, fever, peritonitis. If the patient is not symptomatic, then a kid under the age of 6 who has ingested a cell that's greater than or equal to 15 millimeters, if not, you can manage them at home. If yes, then you would pretty promptly want to follow up with them and get an x-ray in about 4 days rather than waiting the 2 weeks like you do for an older child with a smaller battery. Any questions before we move on? There's a lot on that slide. Okay. So some of the tips and pitfalls, I think the 3 N's is a phrase that gets tossed around in the literature regarding the batteries. These are kind of danger things. Negative, because that's your negative pole of your battery. Narrow, so think about our esophagus and the points of narrowing. And necrotic, if you see necrosis on the mucosa when you're removing it. Those are all things that should make you concerned. And again, the 20 millimeter lithium batteries are the ones most frequently involved in esophageal injuries because of the size, and it's very easy for them to become lodged. Definitive determination of your battery diameter before passage or removal is unlikely in about 40% of ingestions. And I think you may have experienced a similar phenomenon. A kid comes in with an x-ray of a coin. It always looks like a quarter. It always looks bigger. And then you hear they went to the OR and took it out. No, it's just a nickel. So again, there's a magnification effect that happens with the x-ray. And so it's really hard, based on the measurement on the x-ray, to know exactly what size that battery is. You can assume that hearing aid batteries are less than 12 millimeters. Don't induce vomiting or give cathartics like Ipecac. They just don't help. And assays of blood or urine for battery ingredients is unnecessary because what we talked about earlier, the heavy metal toxicity is so insignificant that it's not worth testing for. So as far as estimating your battery size, which we talked about, is hard to do. Here's a slide that shows the lineup of some batteries with their kind of matching coin sizes. And batteries that are larger than a penny, because a penny is 19 millimeters, should immediately be of concern. So that's going to be the 3 on the right side of that slide there. And then these are companion radiographs of those same objects. And again, the radiographs will almost always overestimate the diameter unless the magnification has been corrected. So that makes it hard just measuring there on your screen to determine the size. And then a quick note on terminology. Sometimes the term anode and cathode will get tossed around in reference to batteries, but it really changes in different contexts. What is the anode and cathode is very different on the exterior of the battery compared to what the internal processes of the battery when it's working normally. So medical professionals are really encouraged to just refer to the positive and negative poles of the battery, which on the left side of your screen there is the positive, and then the negative side is always the one that has the rimmed edge. So I saw this picture online of some coins and batteries lined up with their radiographic appearance, and it just looked like a police lineup to me. So I don't know if anyone's seen The Usual Suspects, but it definitely fits the bill. And you know, the dime here, it only committed a misdemeanor, really, if it gets stuck, but he's not innocent. So, but if you look at this lineup, on the far left, actually those first 3 are all batteries. And you can see the halo effect of the small battery, the larger battery, and then the side profile of the next one, and with its little step off. And if you move again to the right, again, that's another battery. You're looking at the negative pole. But interestingly, on the radiograph, you can't really see the halo on that one. And I think that's a scary thing. We kind of rely on that halo to tip us off. But sometimes, depending on the penetration of the x-ray, you can't always see it. So that's where the lateral view is very helpful. Because here you can see, as you move again to the right, there's that same battery turned on its side, and you can pretty clearly see the step off. And so if that child came into the ED and you didn't see the halo on the AP, but you got a lateral view, then you would still have the information you needed. Moving again to the right, there's your dime, pretty classic coin appearance on the x-ray. But the one next to it, to the right, is a really slim battery. And you can see how the coin would look very similar on a lateral view, and you can't really appreciate a thin step off on that one. And so even though we've got tips to help us sort it out, it's not always evident by radiographs either. So this is an x-ray that shows a very typical location of where the battery will get lodged. And here I've blown it up a little bit for you so that you can really clearly see that halo effect. And once you get used to seeing it, it is pretty dramatic compared to what a coin looks like. And then on the lateral view, you can appreciate the step off might be a little harder to see from your seats. But this was a 20 millimeter battery that was lodged in the esophagus at the level of the cricopharyngeus. And so there's just a reminder of our anatomic narrow spot. And this is probably the most likely site of where a battery would get lodged. Now this boy, he was a 15-month-old that I helped care for in fellowship. He came in on a Sunday, and unfortunately he was seen first at another hospital. Well, not unfortunately, but there was a significant time in transfer. It was probably 4 to 6 hours by the time he got to us. By the time he arrived at our institution, it was a pretty quick triage and to the OR. And you can see where his battery was lodged was a little bit lower than the typical location. But if you can tell, it's right about the level of the carina, which I said is another place where they can be lodged. And on the lateral view, you don't, because it's a little oblique, you can't see the step-off as well, but on the AP view, you really can see the clear halo. So the patient underwent rigid esophagoscopy and removal of the battery. We studied him the next day with a contrast study, and he had normal passage of contrast and no evidence of any leak. Definitely when we were in the OR the previous day, there was a lot of kind of coagulation necrosis, that kind of char, and so we were significantly worried about him. But the study looked good, and he was able to tolerate liquids, and so we discharged him home about 36 hours after his endoscopy. He came back to the hospital probably 5 or 6 days later with some respiratory distress and abdominal distension. Someone in his family had been diagnosed with C. diff in the week leading up to that. There was concern that, could this patient have contracted C. diff, and that would explain the abdominal distension. But he underwent, luckily someone was alerted to the fact that he'd been here with the battery within the week, and so the surgery team was consulted. He underwent a CT scan, which demonstrated that he had developed a fistula between his esophagus and his right main stem bronchus. And so that was the source of his abdominal distension. All that air he was breathing in was going into his GI tract. So luckily he was able to avoid positive pressure ventilation. We were able to manage him with an NG tube for decompression, which greatly helped his respiratory status. He was observed in the ICU for several days before he got better, was put on IV antibiotics. Luckily, he was able to get through this without any operative intervention, actually, with distal tube feeds and keeping him NPO. His fistula actually healed spontaneously after about 6 weeks. And he was left with a small residual stenosis of the right main stem bronchus. But he was a pretty dramatic case, and it makes you nervous every time you send one of these kids home after taking the battery out. But in retrospect, looking at where his battery was lodged and the position that we found it in the OR, not that you could definitely determine that's an outcome that he could have, but it certainly could alert you to potential problems that he might encounter down the road, and it might increase your frequency of follow-up or education for the parents, and so those are all things to consider. And again, there's a picture of the esophagus with the relationship with the trachea. Now this is an older child. This was a 7-year-old. And the reason I show this x-ray is to show that because it's an older child, the battery didn't get held up at either of the typical points of compression, either high in the esophagus at the cricopharyngeus or at the main stem. Somehow it managed to get down lower and then just stopped there. And this was a patient that also underwent endoscopic removal and did well. This was a patient that I took care of within the past year, actually. She's a 9-year-old who came in complaining of right lower quadrant pain. And so the initial concern was for appendicitis. No ingestion history that was initially presented. And on her plain films, boom, there's something in that right lower quadrant. And here it is blown up for you to see a little bit closer. I've kind of given it away saying it's a magnet and a battery. But at the time, it was not that obvious. We certainly could see kind of the halo effect on the round portion, but we weren't sure, was this one object? Was it really a battery? Was it two? We couldn't really tell. But we elected to take her, because of her abdominal pain, we took her to the operating room, started with laparoscopy. And we could see that her small bowel was stuck up to the cecum. And as you tease them apart, you could kind of feel the clunk as the magnet let go of the battery. And the wall of the bowel between the two was necrotic, hadn't perforated yet, but it certainly would have happened. And you can see how close those two objects are, and you never would be able to tell that there were two layers of bowel wall separating them, just barely. And her CT scan that we had done, we were trying to figure out, are these two things in the lumen of the bowel? And the CT scan, because of the scatter from the metal, we couldn't really, it didn't help us sort it out much. So we took her to the operating room. We were able to just resect the necrotic wall of the ileum and close it, taking out, that's the side that had the battery, and the magnet was in the cecum. And we were able to, again, resect the wall of the cecum and close that. And so, in retrospect, once we knew that it was a foreign object in there, of course, we'd question the patient a little more directly, and she couldn't even tell us what she'd had. But she had been staying with Grandma, who had hearing aid batteries. And as you can see, this is a smaller battery. So even the smaller batteries, in the right setting, when you adjust them with a magnet, can be as devastating. And she luckily has done really well. Here's a picture of the two objects kind of mimicking how they were in situ, minus the bowel wall between them. All right, any takers on what this is? Just to mix it up a little bit. Doesn't quite look as round as our coins, does it? Any Canadians in the room? It's a Canadian dollar. So, all right, and here's our classic quarter. So again, you don't see that halo effect, smooth and round. If there were a lateral view, it would look pretty smooth as well, but that's good old quarter. All right, what about this one? I don't know if the magnification is good enough, but if you can tell, it's not perfectly round. It's got a little slightly more oblong shape to it. It's kind of subtle from your distance. So I'll give you the lateral view. What do you think about that? Yeah, it kind of has that step-off appearance, doesn't it? But it's not a battery. It was 2 coins. So, but still, if you're suspicious and you can't tell, get that patient to the OR and get it out, because it's not worth the time waiting to sort it out. All right, now this one is a battery that has gotten through the esophagus, obviously, and it doesn't really look like it's in the stomach. It's probably made it to the intestine somewhere. So your decision to remove this battery really is reserved for those patients with abdominal pain, signs of acute abdomen, peritonitis, fever or bleeding. Otherwise, you can watch this and just make sure that the patient passes it. Once they get through to this point, it's likely that the battery will pass on its own. And as you can tell, this looks like it's probably smaller than the 20 millimeter batteries. So the largest, if this hasn't hit the colon already, probably the narrowest point it has to pass at this point would be the ileocecal valve, and it should be able to get through. What about this? These are regular cylinder batteries. So luckily, we don't commonly see these ingestions in kids. The literature says the incarcerated population is more likely. So that's not usually our patients. And you don't tend to see the types of complications with cylinder battery ingestions. So I just had to throw this one in because it was interesting. These are probably double A's or something. I don't know. They look bigger than triple A's, but that's right. Yeah, if they have a D cell, you might need to do something. All right, so this is an endoscopic picture of a 4-year-old boy who underwent removal of an esophageal battery. This is a rigid esophagoscopy. And just to orient you, the anterior surface of the esophagus is what the top of the picture, and posteriorly is at the bottom. So you can see that the negative pole was probably facing forward in the esophagus, and you can see that kind of rim of char at the step-offs of the negative pole. So provided this is probably lodged at the cricopharyngeus, what structures outside of the esophagus would you be worried about in a negative pole facing anterior? Your trachea. Mm-hmm. And think about the char laterally. You'd be worried about your recurrent laryngeal nerves too. So we'll shift gears a little bit and talk about how this can be prevented, because it's certainly, we understand the challenges of how to fix the problem once it's happened, but I think we'd all like to be able to back up the clock and prevent it before it even happens. So there has been some work in the industry. There is a standard for audio-visual and similar electronic apparatus safety requirements that specifies that button and disc battery compartments must be contained, and either a tool or a minimum of 2 simultaneous independent movements required to gain access to the battery compartment. That's UL 60065, I guess. This consensus was reached by the industry in April of 2012, and mandatory compliance comes into play this coming January. There are also some newer standards that are in development that address stress and abuse testing and battery replacement testing. And this is where I get to the part where I say I have no interest in Energizer. But I think as a company, they have really done a lot to promote the safety of this product. So probably the biggest thing they have done is in terms of education and outreach. They've written letters to the medical community and device manufacturers. They've been actively participating in the voluntary standard setting process that we just talked about, really leaders in that process. They present at conferences and participate in those types of academic scholarly activities. And they've really been at the forefront of a big public awareness campaign called the Battery Controlled, and have partnered with Safe Kids Worldwide. If you go online to Safe Kids Worldwide, you can get access to this safety sheet. It's a great resource for parents, and I think you guys might even have it in your packets with you. So that information is out there. There's also a little PSA video online that we don't have time to watch today, but is great to watch and good information for parents. They've put out a lot of other documents, kind of safety fact sheets geared towards parents with the kind of idea of the 4 S's: store, select, secure, and share. So you want to store the devices safely. You want to select, of course, their batteries in the proper packaging. You want to secure the battery compartments, make sure that most of those are compartments that have to be screwed shut. You want to make sure they're secure. If not, tape it shut, do something to secure that battery compartment. And you also want to share that information with other parents. They've also been involved in battery compartment design, so that industry standard 60065 Energizer was really key in leading that push. They're also working on trying to improve the battery design itself and maybe change the battery composition or the design so that it is not harmful when ingested. We're not there yet. They've also come up with new warning labels that are on the back of all of their batteries. They're working towards a keep out of reach of children safety recommendation. I didn't realize it had to be an official recommendation, but they're trying to get these batteries included in that. They're pushing their warning label to maybe be adopted more broadly among the industry. And removal of that warning label on the negative pole of the battery is necessary for the battery to work in the device. Unfortunately, that sticker doesn't provide any safety if it's ingested with a sticker in place, but it helps alert parents as to the warnings of it and the dangers. And they've also revamped their packaging this happened back in 2012. They now have new child-resistant packaging that meets the U.S. Consumer Product and Safety Commission guidelines. It's a much more durable and flexible material, and it includes improved warning copy and the safety pictogram on it. Interestingly, if you go online, there are lots of parent blogs that will mention battery safety, and there are a few blogs that I ran into that showed parents trying to open these packages and how difficult it was. And really, you can't tear, you really have to cut the battery compartment open. And an interesting key safety feature of the Energizer packets is that if you cut it open to release one battery, the other battery is still protected. So it doesn't necessarily release both batteries. So that's a key safety feature. Now, legislation. Everyone's favorite bastion of productivity. There is, in the Senate, there's a button cell Battery Safety Act, Senate Bill 1165, that was introduced by a couple senators from West Virginia and Arkansas back in 2011, and we all know what year it is now and what year it almost is. But it was referred to the Committee on Commerce, Science, and Transportation, and it's aimed at requirements of product safety standards actually for the items that contain the batteries. And it's still in committee to be determined. So who knows when and if that will ever make it out of committee. But I think more importantly, the industry efforts independent of the government have probably been the prime mover in establishing higher safety requirements for these devices. So some key points to remember. The incidence of injury from button and disc batteries is clearly increasing. Prompt recognition and removal is the key, and remember that significant esophageal burns can occur in as little as 2 hours. Children under the age of 6 years, age of 6 years of age, I got a little happy with the redundancy there, but under 6 years of age, those kids are the most vulnerable, and it really takes a high index of suspicion in order to avoid any misdiagnoses. Batteries greater than or equal to 20 millimeters in diameter are the most dangerous due to their size. And really, prevention is the key. So spread the word, tell parents you know, people in daycares, we use them in the hospital all the time too. I see these batteries in our NICU stock rooms. I'm sure they work in all of our devices. But just tell people, make sure they're aware of the dangers so that as many people can be alerted to this as possible. And again, the National Battery Ingestion Hotline, if anyone wants it, didn't get it earlier, it's 202-625-3333. And after the talk, we'll have some dead batteries in the back free of charge. That was for you, John Petty. All right, and I'm happy to take any questions. All right, thank you very much. Oh, there's someone.
The double A's, triple A's, whatever those were.
Mm-hmm. Typically, those will pass on their own, and it's pretty rare that we see a kid ingest those. That actually was an adult patient that had done that. But in those circumstances, you can treat it as any other retained foreign body if it doesn't pass on its own or if it causes symptoms. If you can endoscopically retrieve it, if they stay in the stomach, if they get into the small intestine and become impacted there, then that would more likely require surgical removal. Definitely, you're stealing my talk for next year. But yeah, we've seen that too. The magnets are just as dangerous, and there are pushes in the industry to rid those in the toy realm. But as you saw how the magnet and the battery interacted, the same thing would be true of multiple magnets. They can, loops of bowel can get stuck to each other with batteries inside each, or magnets inside each, and then the intervening walls of bowel get necrotic. So I agree, the magnets are extremely dangerous as well. Luckily, they don't have quite the esophageal injuries that we see, but they are similarly dangerous. Thanks for bringing that up. Yes?
My mom likes to send my kids cards every holiday, and she's sending the ones that's spinning and have writing, and they all have these batteries, and all you have to do is get the battery out, and they're aimed at children. Is there any move to make rules to regulate those?
I'm not sure if Hallmark has undertaken that, or I would think one of the card industries should be at the forefront of that. Luckily, most of the batteries in those types of devices are the smaller batteries. It's rare that those have it's really rare that those have the 20 millimeter disc batteries. I think they're almost always exclusively the smaller hearing aid type batteries. So that's one thing you can at least sleep easier about. But those batteries we know aren't benign either. And depending on the age of the child, there can be consequences from those too. So just be mindful of where those things are in your house. As I said, these types of batteries are just ubiquitous. I mean, they're in places you would not think of. They're in your key fob, for your little remote entry for your car. How many times don't we leave those sitting out on the table where little hands can reach up and grab them? And for the most part, those battery compartments are usually secured with, tiny screws or something, but how often do they fall and break or get stepped on? And so you really have to, as a parent, I have a 15-month-old right now, and I just, in preparation for this talk, I just look around my house and I'm like, oh my gosh, it's just a minefield in here. And so I tell everyone I know, and I've told my husband, I was like, watch out for these. We were at a children's museum of all places, and my husband we were with two different kids, so he was kind of behind where I was, and he was walking through the hallway, and a woman stopped him and said, "Oh, is this your battery on the floor?" And he looked down, and there was a disc battery, and he said, "No, it's not, but I'm picking it up and throwing it away." So it's really scary how easy they can be for little hands to find. A toddler's not going to tell you, "Hey, Mom, I swallowed the battery." They're going to have really non-specific symptoms, and so that's why the 2-hour window is so impressive and scary. Yeah.
Is there anything special for disposal in those batteries? I mean, is there something different you're supposed to do, or lock it up?
Lock and key. I've got a safe. Well, a lot of these batteries can be recycled, and so they can be returned to recycling centers. Some people will have recommended that you put tape on either side of the batteries, covering up the two poles, before you toss it in the trash. But from what I read about the warning labels on the Energizer batteries, they say that their warning label, if ingested on the battery, it doesn't provide protection. And maybe that's because the positive pole is still exposed. I don't know. But I worry that just putting tape over it might not be sufficient, but it certainly wouldn't hurt. So I think that's not a bad idea to kind of tape over those two exposed poles before you throw it away, or just take it to a recycling center and keep it locked up until you get there. All right. Oh, one more.
Depending on the age of the child, would a mild laxative help if you already know that it's infant with its head stomach?
It might. The data hasn't really shown that it's significantly helpful. I don't think it would provide any significant harm, although I did read in one of the articles it was a theoretical concern, but they worried about the electrolytes in Miralax or some of those other preparations that could it potentiate the battery's activity. But really the thing, as long as the battery is moving, it's not as much of a danger. It's when it really becomes lodged in one place that it's more destructive. So it's hard to say whether or not Miralax, Go Lightly, any of those kinds of things would. I don't think they would definitely be harmful. And if you've got a battery that's moving and it's made it out of the esophagus, I don't think it would hurt to try that.
I have a friend that has a little one with cochlear implants, and I know those are a lot smaller, but she's already had at least one instance of swallowing. What's the best recommendation for because when they're wearing them and take them off and on, or I've never looked that close. How secure are the compartments for the hearing aid?
I'm not definitely sure. I would assume that with newer standards, they would need to be as difficult to open as the industry standard. But I'm not sure how it applies to medical devices and whether or not they're under the same type of rules and regulations. But one thing I forgot to mention in the talk, but some of those smaller batteries, if you get an x-ray and you can't see it, you might consider, is it in their nose, is it in their ear? Because vagina. Kids will stick things crazy places. And so if you don't catch it on your x-ray, those are some of the other places to look. Now, those children may not be presenting with some of the respiratory complaints, but if it's in their nose, they might be. So, all right. Anyone else? Yeah. I think there's a possibility that it could get through, but I think it's really difficult. Those are the quarter size things. Those get stuck. The odds of them passing it are pretty low. Luckily, it does. It's like I said, it's a really infrequent thing. It's just so devastating when it does happen that the outcomes can be really dramatic. So for the most part, it doesn't happen that often, but the risk is omnipresent out there. It feels like.
So the first case you showed where the child died, I mean, were they in the hospital or CCU?
Well, from what there was not a whole lot of information because it was a news story, but the child was, I think, called, or the EMS was called to the house because the child was found kind of in extremis. I don't know if there was, bloody emesis happening or what the compromise of the child was, but EMS was called. They rushed the kid to the hospital. I don't know how long the hospitalization was, but and I couldn't really tell. I don't know if the child was maybe even found down in the home. But there was an investigation into the family after that, and then about a month later, the autopsy report came out saying that the child had ingested a battery. Well, thank you very much for your time.